Good day, global citizens. Welcome to another episode of Dr. Fajembola'S Opinion. This is a platform where research meets understanding and legacy. I'm so happy about today's discussion because I'm a woman and it's one of the discussions in the health sector, which is, I would say, rarely discussed in terms of research. I brought someone today from the eastern region of Africa, Uganda. And many of you know, if you've watched our previous episodes, you know we've had about two or three guest researchers from Uganda. We will take you through what you should know about uterine rupture. Today's discussion is based on a case of a 33-year-old woman who had uterine rupture at um, 18 weeks, which she had two children, and it happened by her sleeping and falling in the toilet, something maybe toilet or floor. I guess researcher will give us more details on that. So do join me to welcome Dr. Henry Kaggwa. Dr. Henry, how are you doing today?
I'm fine. How are you, Dr. Fajembola?
I'm good. Thank you so much for accepting the invite, and I look forward to what I and also our audience will learn from you today. Let's take you through the biography of Dr. Eric Agua. He's a passionate, licensed, and experienced medical doctor in Uganda, East Africa. He's an early career researcher and co-founder of HealTorch Foundation and Medical Center. He relentlessly strives to increase healthcare access in rural areas with a bias and infectious and non-communicable diseases. It prioritizes patient-centered care, disease prevention, and health promotion through health education, research, and tech-based innovations. He's a pragmatic leader, an alumnus of Aspire Leaders Program and Millennium Campus Network Fellow. He has been twice a team leader on the Global Admission Committee of Millennium Campus Network, supervising a review of 50,000 plus university student applications from Africa, Asia, America, and Europe. He actively participates in agriculture and environmental conservation, producing organic food. Dr. Kaggwa is affiliated with Busitema University, Uganda, Communications Commission, and Mengo Hospital, where he supports the surgery department in research. So before we dive into how we do, we look at what global citizens are saying about our discussion for today. What are they saying about uterine rupture? The first tweet is from the data scientist, where he or she said, "We had a 40-year-old gravida 9 para 8 plus 0. Gravida 9 means 9 children. They have been pregnant 9 times, and para 8, they have 8 children, impending rupture. Baby out resuscitation starts, but the uterine bleeding was too much. The guy realizes we are split between joining neonatal resuscitation, arresting the bleeders. Then he shouted, "We are gynecologists, not pediatricians." Mother first. So this happens a lot, and that's why I'm taking care of the mother. It remains one of the top multidisciplinary areas in healthcare. Um, Another tweet is from Forever LSU, where he or she said, what the person was replying to a tweet. Furnish is accusing others of pedophilia, considering their religion allows the marriage of very young girls to older men. Don't say this doesn't happen. Here is an article from Rupture. It's from 2013 about an 8-year-old girl dying from internal injuries and uterine rupture on her wedding night. I don't know where this comes from and who they are referring to, but at 8-year-old, getting uterine rupture is very weird. Who is getting transferring their child at 8-year-old in this generation to get married? The last tweet is from Maribel Sale, where he or she said mifepristone can have serious adverse effects, including sepsis, infection, hemorrhage, hospitalization, uterine or ectopic pregnancy rupture, or even death. Be aware of the risk before taking this medication. Um, I see no reason why one of the drugs, I don't know why, I see no reason why anyone, in this generation we are today, I know doctors, number of doctors globally, it's reducing and the workload is increasing for doctors, but that does not mean you should take drugs aside paracetamol that you are aware of. You should take drugs anyhow without the prescription or the guidance of a medical personnel, not especially mifepristone when you are pregnant again. Pregnancy is a very delicate health condition. Even an elderly person shouldn't take drugs anymore, let alone a pregnant person. We all make mistakes, we are all growing, but this is a platform to create more awareness and improve the knowledge on health literacy of global citizens. So, Dr. Eric Kaggwa, we are diving into the questions on what our audience should know. Our discussion today is on uterine rupture. And
Yes, please.
in the paper, non-traumatic uterine rupture was being repeated. I mean, in the paper, traumatic uterine rupture was being repeated. And going through the paper, you come to ask, like, is there non-traumatic uterine rupture? We know that traumatic uterine rupture accounts for 10% of all cases of ruptured uterus.
Yes.
What makes it traumatic?
Mother fell in the bathroom and sustained an injury to the gravid uterus at 18 weeks. So, having been a victim of a fall with a result of injuries from the fall makes the case traumatic, because had she not fallen down, she wouldn't have sustained this rupture we had. I don't know whether I've been able to answer your question.
Okay, thank you so much for that brief reply. Now diving more into the discussion, tell us about this case. This is a case of two patients, two departments. A 33-year-old woman who had ruptured uterus with two previous scars. What should we know about this case?
Well, first and foremost, this is the first case of its kind in Africa. To have such a young pregnancy, encountering a problem of uterine rupture, then we go into theater, repair the uterus, the pregnancy grows, and the mother delivers a live baby. It has not happened anywhere in Africa. If it has happened, maybe it was not documented, but according to the available literature, it's the only available case to have been documented.
Okay.
So, this mother, as the case reads, because I'm the first author, I led the surgery. So the mother fell down in the bathroom at home. She was rushed to a nearby medical center, but health workers there didn't suspect that maybe she had a uterine rupture. So as her condition deteriorated, her case was escalated to a major hospital. That's Mengo Hospital. Mengo Hospital is the first hospital in East Africa. It's now 128 years. So when we received her, we did baseline investigations, and ultrasound scan showed the hemoperitoneum. There was blood in the in her abdomen, but we couldn't locate the source of bleeding. So we resuscitated with fluids, normal saline, about 3 liters, but her vitals, especially the blood pressure, kept on dropping and her pulse was rising. So we
Wow.
decided to go in and find out what's really happening in her abdomen. So we are suspecting 2 things initially. We thought maybe either the liver or the spleen, because we know in most falls or accidents, usually either the spleen or the liver gets injured. So we went in. It was it was coming to midnight. We went in and opened up, checked the liver, okay. The spleen, very okay. Looked at the main century of the intestines, no bleeding. Now, actually, before that, we evacuated about 4 liters of blood in her abdomen because she didn't have any bleeding. She didn't have any vaginal bleeding. So all the blood was concealed in the abdominal cavity. So the my assistant told him, no, let's check on this uterus because it was small, 18 weeks. There was just something small. But like, no, but this gestation age is not susceptible to uterine rupture. The pregnancy is still young. We're like, no, but now we're not seeing any source of bleeding. Where bleed becoming? Now, on checking the uterus, the lower segment, we found there bleeding. So we repaired. We transfused that about 4 liters of blood prior to discharge. So repaired the tear. We closed that up. We almost took her to ICU, but she wasn't so bad off, and we were there to keep monitoring in the recovery room until she was a bit stable. Then we took her to ward, kept on monitoring. Now, because there were 2 teams now involved, the surgery team and the obstetrics team, because the woman was pregnant and the people who had done the surgery were surgical team. The gyne team had to come in to manage the pregnancy, and the surgery team had to be in the know of what's happening to the wounds which had occurred. So we worked together. Around the 5th day, we discharged the mother. We kept on following up. Actually, I convinced her that now, don't go back to Lubaga because she was already attending antenatal to Lubaga Hospital. Lubaga Hospital is the second oldest hospital in Uganda. So I convinced her to come back to Mengo. We kept on tracking her pregnancy with ultrasound scan, but everything was okay. Actually, she told us that in their village where she stays, neighbors told her, no, they would have removed that baby. That baby is not going to survive because now the uterus was ruptured. Maybe even the water came out. So that pregnancy is not going to survive. It can't happen. But we kept on hoping because even the literature didn't show us any such documented case in Africa. Actually, I saw one in USA where the traumatic uterine rupture occurred at 22 weeks and the pregnancy survived. So we kept on hoping. I kept on following up with the team. Slowly, the pregnancy continued to grow. Now, at around 37 weeks, I think one of the doctors missed out placenta previa. Realized that the mother has a placenta previa. Now that one made us to increase our vigilance and also give her extra precautions to ensure that we are not caught off guard in case of antepartum bleeding. So she came in on the due date for a C-section. Because she had 2 previous scars. Actually, the risk factor which we found out in her case why she could have sustained this day, she had 2 previous scars, but they were old. The latest was about 3 years.
Okay.
So we did the surgery. got the baby out, though she bled a lot because of the placenta previa. We used the D-Lynch to achieve hemostasis, and she went back to ward. We watched over her. The baby was okay. And on the third, fourth day, I let her go home. We kept on following her. Actually, up to now, I still follow up on the mother. The baby is okay. The baby is running. Actually, my sister, I'm a general practitioner. She keeps on telling me how the baby is. If the baby has any problem, as we saw in my biography, I prioritize telemedicine. So many times, may not even come to the hospital. I put on a video call. The baby has this and that, and I do prescription. I'll send her to do some tests, and I treat her virtually. So the baby is okay. I even have some photos, current photos now, of this miracle baby. Yes.
Good baby. Thank you so much, Dr. Eric Kaggwa, for that elaborate story. You give us, it's quite interesting to see and quite great to see what medicine can do to the lives of people. Like you said, people in the community, they were like, this baby can survive. And with the help of timely medical intervention, a life was saved, and also the death of a baby. Dr. Henry, when I was in Uganda, because I did not graduate in Uganda, for our new audience who just know, those who are our old audience, they know, I found out that some people use traditional means for family planning. Some people don't use family planning templates, like they have some apps they use for family planning. That was part of my final year in Saza Masaka.
That's nice.
So I want to know what uterotonics are available to the community in Uganda. Are they just medications or also local medications like apps that women use to ensure delivery?
Well, uterotonics are many in Uganda. The hospitals majorly have oxytocin, which has to be preserved at 2 to 8 degrees Celsius from lower health facilities like Health Center 4 up to national referral hospitals. They all have oxytocin. They also have misoprostol. It's a prostaglandin. It has been helpful. Actually, many hospitals in Uganda, they combine the two. Immediately after birth, they give intramuscular oxytocin, and then they give 600 to 800 micrograms of misoprostol, either rectally or sublingual. Then some advanced hospitals like at Mengo, Lubaga, they have heat stable carbetocin. Though it's expensive because it costs about 250,000. For it doesn't need any refrigeration. So if it's made available anywhere, it can do a great job, because we've made circumstances where oxytocin is not working because people don't have refrigerators to keep it at its optimal temperatures. Other available uterotonics, there is carboprost, though it's also expensive, and it has a bad side effect. There's no good side effect, but this one is quite offensive. The women who usually get it, many times they get diarrhea. Carboprost, yes. Then also gometrine, though non-trade available, and it's used in refractory cases, maybe secondary PPH, or where you don't have betocin, you can as well use it.
Okay.
Then traditionally, just as the study talked about in Masaka, people have their own things they use. Some have roots, others use certain plants they chew. And actually, some of them have active ingredients, and some have led to uterine ruptures. Yes, though
Okay.
I think we need more studies to really identify these plants and also go biochemically to find out which ingredients are in these plants. Because as you may know about some of drug discoveries, for example, quinine. Quinine was discovered from chikona tree. The man was moving and had malaria. He slept near the river. Then he drank water of which the chikona tree roots were seeping into that water, and the man ended up healing from malaria. And that was the genesis of discovering quinine. So I think even these plants our people use locally to induce, to augment labor and all that, they can be studied further to know which other active ingredients would be there. You may find that they could be resembling carbetocin, which doesn't need refrigeration and can be made available everywhere in Uganda, because Uganda, I think the electricity coverage is about 40 or 50%. So those rural health facilities, if they don't have cool boxes, they have big challenges in keeping oxytocin. Thank you.
Okay, thank you so much, Dr. Henry, for giving us that. Actually, for those who don't know what uterotonics are medications that help contraction of the uterus. Many women use uterotonics actually when my delivery, many people don't know about my delivery. I'm going to share part of the story today. I was giving birth on the road. And when my mom was pregnant, in those days, they gave her like traditional apps. In Nigeria, they call them agbo. So she was secondly twice pregnant. So she gave birth to me. My delivery was easy. She said I just came out easily while she was on the road. I can imagine not how small I was, but the process of labor, engagement, and the rest. Like how did it happen?
Yes, yes.
I just came out. So it's apps have been used since time immemorial, and medicine keeps getting better. What its difference is modern medicine is gauged. The dosage is gauged compared to traditional medicine where it's not gauged. You can just drink like 5 cups, 3 cups, two
Yes,
cups, you understand,
yes.
compared to modern medicine. So thank you so much for
Others,
that.
Americans. Yeah,
So not
yeah,
just in Uganda, across Africa, and I believe across the world, every community has traditional uterotonics they usually use. Some people even say eating pineapple works in contraction of the
yeah,
uterus. What we are saying is don't do anything, especially when you're pregnant, without informing your physician, without informing your health practitioner, without informing your traditional health attendant, especially as a
yeah.
pregnant woman. So, Dr. Henry, what are the 3 causes of uterine rupture? Because in this case, the woman fell. Um,
Yes.
Reading the paper, I came across different causes of uterine rupture. What are 3 top causes of uterine rupture?
Well, the 3 top causes of uterine rupture, they may vary from one region to another, but generally, the commonest cause is having a uterine scar. Like if a mother has ever had a scar, has ever been operated before, it can easily lead to a uterine rupture compared to a mother who has never been operated. Then you have things like obstructed labor. Many times, maybe the baby has not engaged well, the baby is big. That obstruction has led to many ruptures across the world, especially in developing countries where there may be a delay to do emergency cesarean section, and a mother ends up having even the bundles ring. So you know that kind of happens. Say so. Um, Pathognomonic to uterine rupture if a mother develops a bundles ring resulting from obstructed labor. Now, other things like if a mother has ever had any surgery, like myomectomy, removal of fibroids, though it can also group it to previous surgeries, those previous cesarean section, that mother can easily end up with a uterine rupture. Now, we have augmentation and induction of labor. Just as I hinted on and also talked about, our communities, people use traditional uterotonics, either to induce, to augment labor. So even in hospitals, many times health workers attempted to use oxytocin to augment labor, others to induce dinoprostone, misoprostol. These can lead to uterine rupture because there will be accelerated contraction of the uterus and we end up having a uterine rupture. So those are some of leading causes of uterine rupture in Uganda and also globally.
Thank you so much for that, Dr. Henry. In one of our previous discussions, we talked about gender-based violence, and it's often overlooked as an etiology, as a cause of uterine rupture. So, and this is for those, especially who face physical abuse. This is for those, for men who engage in physical abuse, and for women who are constant at the constant end of receiving physical abuse. This is to tell you, to let you know that physical abuse, it can also cause uterine rupture. We put you and your baby at risk. So thank you so much for that, Dr. Henry. This is a beautiful case. It's a unique case. As a medic and as a researcher, what challenges did you face during the management of this patient?
Yeah, just as I said that it was first of its kind. Actually, I got a lot of praises about this case. Even the person I was with were praised a lot, having successfully managed this case. But just like any other good thing, challenges are inevitable. One of the challenges we saw, we can categorize them. Some were facility-based, others were just system-based, because realized that this mother fell down in the bathroom at 10 a.m. But we received her in the major hospital at 4 p.m. And we ended up making a decision to operate on her when it's coming to midnight. So
Wow.
some of the
Wow.
challenges you find that the delay in moving this mother from a lower health facility, coming to the hospital, making a decision, because her case was also not so clear from the look, cause she was not bleeding, there was no any physical injury, but she was bleeding internally. So even the scan, because we wanted to do MRI, but the mother didn't have money, and the MRI could cost about 800,000 Ugandan shillings. So we decided not to do the MRI, because maybe for it would have give us a detailed images of how the uterus is compared to the first scan, which didn't show us where the bleeding is. So the limitation of finances on the patient side, because this was a private hospital, private not-for-profit, made us to get delayed in making the decision. Because what informed us more was the dropping blood pressure and rising pulse, despite the resuscitation we were doing. Then maybe another challenge, being a first case, we were more of not so certain of how the case was going to evolve. The drugs we were using, because at one point I had to fight with some fighting, but we didn't physically fight, with surgeons who wanted to give again other drugs. Some wanted to give metronidazole, because in most cases every surgical patient receives the metro. I had to come in and advise, no, she's gravity, we don't need to give metro, we can have other options. So it was really tug of war in resolving some of these challenges, because it was multidisciplinary, but you find that since it's first of its kind, there was more of those dilemmas. But we thank God we reached a conclusion and had successful outcome. Maybe another challenge, the community where the mother lived at one point demoralized our patient, telling her that that baby won't survive. The baby will die in utero. They would have removed that baby. It greatly affected our patient's emotions. However, we came in to give her the right information, and she trusted us, and we continued to move the journey with her, and we had the good outcomes. Yeah, those are some of the challenges we had, but maybe another thing, the case drained the patient because she spent about close to 5 million on the patient side, because I don't want to look at the challenges only on our side as doctors and the hospital, but also to the patient.
The
She had to
patients.
spend, yes, she had to spend a lot of money in the hospital. As I told you, it's the oldest hospital. It's one of the best hospitals in Uganda. So she ended up
Yeah.
spending a lot of money. Yeah. If this mother was maybe in rural health facilities, she would have
Yes.
died. She would have died when nothing has been known about it in rupture. Perhaps if they did
Exactly.
the postmortem, that's how we would have known that she had a rupture in the uterus.
Exactly. So thank you so much for sharing your side and also the patient side of the challenges faced on in management of this patient. And also this is a platform to let relevant stakeholders know what to do, what part of our health sector need improvement. And also the community, how they can come in. When a woman is pregnant, like, you don't discourage her, you say good words, you encourage her, you help her cycle, you give her psychosocial support. This is to
Yes,
people too. Like, and this is why we have platforms like this. So people will be aware, so people will be educated, so people know what to do when you come across patients
yes.
like that. So people know what to do when they have a patient facing a particular health condition. So thank you so much, Dr. Henry, for sharing your perspective on the challenges faced from the hospital to the doctor and also the patient. A quote from your paper said post-operatively antispasmodic is crucial. Like post-operatively antispasmodic is crucial. Now I encourage our audience to go to read the publication. What is an antispasmodic and how what role does it play in this case?
Well, the antispasmodic is a drug which reduces or which works against the spasms. Spasms are like twitches in the muscles. So the uterus has about 3 layers of muscles. So antispasmodics help us to reduce or to prevent or to treat spasms when they occur. So in this case, we use the Uterine. That's NOSPA, a brand called NOSPA. It helps us to ensure that this uterus, remember, the placental tissue was exposed due to the rupture. So we had made a figure of 8 sutures. So we literally disturbed this uterus, and we anticipated that the uterus may start contracting, leading to expulsion of the baby growing.
Exactly.
So we're giving this antispasmodic to ensure that there is no such contractions being initiated in the uterus. And also previous studies had shown the same being effective in treating the spasms occurring in traumatic uterine rupture, where the baby or the pregnancy was preserved. I give you a case of 22 week old pregnancy that survived in US. Yes.
Yes. Thank you so much for that, Dr. Henry.
Welcome.
it's people often forget, although some of us have big tummies, people often forget that the stomach is made up of muscle, not just fat and skin. So it to prevent the expulsion, the release of the baby, you have to give drugs to prevent, what are they calling it, the contraction and also the spasms that the mother might experience post operation. And this is also for medics who in future might come across such patients to know what to do post operatively. Um, a woman might face uterine rupture, traumatic or non-traumatic. Now we are looking at traumatic uterine rupture. What are the complications of traumatic uterine rupture? I know we've
Well,
mentioned some over our discussion, but what are the complications?
yeah, a traumatic uterine rupture has many complications. Some of them could be removal of uterus, hysterectomy. You may find that the uterus has gotten worse tears in that you can't repair it. So in that case, you may end up doing a total hysterectomy where you remove the mother's uterus, the womb, and that may render her infertile. Other things you can as well do subtotal, still the mother will be rendered uh, infertile in that she can't bear children, resulting from the trauma, injury that happened to her uterus. Other things, the mother can bleed terribly, hemorrhage, she can lose a lot of blood. Now in the healing, the heart may get issues. We've seen mothers getting dilated cardiomyopathy, resulting from pregnancy itself. But now if the pregnancy is again complicated with traumatic uterine rupture, it may be accelerated. Other complications that may result from traumatic uterine rupture, the baby can die. And actually, in many cases, in about 80 to 90% of cases of traumatic uterine rupture, the mother, actually not even the rupture, but trauma during pregnancy. The mother, if the trauma is really severe, many times the baby dies, the fetus dies, either from the impact or from the drugs given, because we may find that now the mother's life is in danger and you have to prioritize it more than the
Yes,
fetus.
yes, of
In doing
course.
that, the fetus ends up dying, others ends up with fetal complications resulting from the medicines that were being used to treat the mother. Other complications that may arise from traumatic rupture, which may not be obstetric, but maybe gynecological fistulas. You may find that maybe during the operation or when the mother fell down, had fractures, now maybe pelvic fractures, pierce the urinary bladder and all that. It can lead to fistulas and other things. Then there is Sheehan's syndrome due to loss of blood during pregnancy. So if a mother
Mhm.
sustains a uterine rupture and she bleeds a lot, chances of her getting Shan's syndrome compared to mothers who delivered normally. Because if those who delivered normally and end up with PPH can develop Shan's syndrome. What about this one who has bled a lot? Now, for example, in our case, she lost 4 liters of blood.
Wow.
Depending that may take time and yeah, those are some of the complications that may result from traumatic uterine rupture. And also death. Many mothers have died. If you want to take it also as a complication, many mothers have died from traumatic uterine rupture because already pregnancy makes her vulnerable. Now, when you add on the trauma, things really worsen. And if the healthcare system is not all that good in that area, the mother may succumb.
Thank you so much for that. Giving us a journey through the complications a mother and a baby might face from traumatic uterine rupture. What are the risk factors of this condition? What are the risk factors that might lead a woman to traumatic uterine rupture?
Yeah, risk factors are quite many. As we said, if a mother, for example, drawing from our case, if the mother has ever had a C-section or any surgery to the uterus, her chances of getting a traumatic uterine rupture increases compared to someone who has never had such surgeries. If the mother has ever had many children, like multigravida mothers, their chances of having a uterine rupture increase compared to prime gravidas. Gestation, multiple gestations, like if a mother has more than one baby in the uterus, if the impact comes in contact with the uterus, her chances of uterus rupturing are higher compared to a mother who has only one baby. Then also the gestation age. Just as in this case, we didn't suspect early enough that this mother could be having a uterine rupture because the gestation age was still young, just 18 weeks. But as the pregnancy grows, the uterus stretches. So it's a likelihood of rupturing after an impact are higher compared to when the pregnancy is young. So as the pregnancy grows, the likelihood of the mother having a uterine rupture also increases. Then domestic violence, gender-based. Families where they're in constant maybe fights and all that, chances of that mother having a uterine rupture are high. Because if a man gives the hard blow and the woman is very
Gives her three hard blows.
so the one can end up rupturing. We have not seen actually, unfortunately, that some of the cases I've handled, we found that the uterus is intact. But literature shows us that when someone boxes a gravid woman, chances of having uterine rupture are high. And that would be
Some men
trauma.
are athletes. A gravid woman, you box her and your child. Some people is not even their wife, someone else's wife, and they box her and the child.
No, these things. When a woman is pregnant, the hormones, progesterone, estrogen, at play. So at times the emotions that come up with the pregnancy, and if the
Yeah.
partner is not experienced to handle such or to recognize that now these are just
It throws us
emotion emotion rages,
throws us
a
some
fight,
blows.
a fight may ensue. So maybe other risk factors in where I am in Uganda,
Yeah.
people use commonly borders. You know, Uganda, people use those motorcycles.
Mm.
So mothers actually advise them, if you start up pregnancies has grown maybe 30 weeks, avoid borders because you can easily fall off from a border. It can easily because just two tires can easily skid off and falls down and you end up with a traumatic uterine rupture. So also get involved in high contact sports. Find someone is pregnant, they want again to do some certain things, so it can predispose you to traumatic uterine rupture. So those are
Thank
some
you
of
so
the
much.
factors. There are quite many others, but those are some of
Thank you
things.
so much, Dr. Henry, for giving us the risk factors. So women and also men. Tell your neighbor, your friends. People should know about the risk factors of uterine rupture. When you see a woman, she's a delicate person. When you see her even engaging in any activity that might predispose her to uterine rupture, you tell her. So this is why we have this platform for everybody to know, so we can help each other build a healthier ecosystem. So, Dr. Eric, the last question I have for you. This is a case of a traumatic uterine rupture, and trauma is the
Yeah,
leading non-obstetrical cause of maternal death. Cases of
yes.
trauma are increasing. annually because we have more influences to trauma as a generation. Where do you see trauma on the continuum of maternal death in the next decade? Do you feel in the next decade, since we're having more trauma influences to trauma, more exposure to trauma as a generation, we'll have more cases of maternal deaths in the next 10 years?
Yeah, I see the next decade having more traumatic uterine rupture leading to maternal death, especially in developing countries, where some of those factors I talked about prevail a lot. For example, usage of borders. Actually, in Uganda, I find that almost every day we lose about 3 people to road traffic accidents. So Uganda now has many vehicles, about 2 million cars, about 1 million motorcycles. So this influx and increased usage of these motorbikes and cars predisposes us more to uterine rupture compared to the past years, where maybe people would walk, where the vehicles were not so many, where people would drive well, and also people, some of these drivers, they drink alcohol and then drive. So same happens to border riders, the motorcycles. So we find that such things will increase many mothers to get involved in uterine rupture, because many poor people are using those motorcycles to come to the hospital, and even poor people also have a right to give birth, so they conceive, use such means of transport, which makes them vulnerable to traumatic uterine rupture. There's a road in Uganda called Northern Bypass. The minimum speed is about 170, the maximum 70 kilometers per hour. But you find
Okay.
borders are also on that road. So in such case, you realize that in case of any injury, any accident, actually no longer call them accidents, they are crashes, because there's someone in the wrong, and when there's something wrong, it's not an accident. Maybe someone's just
Yeah.
negligent. Yes. Then increased gender-based violence. As you see that resources are becoming scarce, the cost of living is increasing, our mental health is being affected. In Uganda, there's a famous headline which showed that 14 million Ugandans have mental issues. and
So
and by the
these
way,
are having to tell people that marry anyone, make sure you do a mental health assessment test to make sure you are not marrying a mad person.
yes. And actually, it correlates well with the with the WHO's statistics about mental health globally. So
Okay.
people are depressed. You find that school fees is high. You can't afford this. You can't afford. So when you become pregnant, small, which can make you fight with your woman, which the woman can provoke a man, and in doing that, the gender-based violence comes up and to increase the traumatic uterine rupture. Then
Okay.
another thing which I think will also lead to this traumatic uterine rupture, the increased the refugee people fleeing their countries, going to other countries. I find that in those refugee settlement camps, many times there are a lot of fights, those sources and all that. So fights will really accelerate, because we're seeing that now Uganda has about 2 million refugees in Uganda coming from all over Africa. So such things accelerate gender-based violence and result into uterine rupture. So all that collectively will increase uterine rupture, and it will get a place on the rankings of the causes of maternal deaths in the next decade. Maybe another thing which I want to also highlight, more women are driving these days, especially in developing countries. And being a driver, when you're in a vehicle, there's a driver, the co-passenger, and people may be behind. So the co-passenger and the driver are at high risk of coming in contact with maybe a collision compared to people maybe at the middle and also maybe at the back. So as more women getting involved in some of these economic activities, others maybe the bus drivers, truck drivers, others now also do conductor. They do as I call them conductors in Uganda, where you pick passengers, put them in the taxi.
Yes.
Others also ride border borders. More women by the riding border borders. And when a woman is pregnant, she will continue with her work because if she may be 20 weeks old, she fed off her family. So also
Exactly.
the emancipation and the changing landscape of economic activities, those were initially preserved only for men, now also women are doing them. And being pregnant may not be an excuse for her to stop getting involved in her source of income. So that exposure makes her more susceptible to trauma, and if she's pregnant, chances of having a traumatic uterine rupture may be high. So those are some of the things which I think may make traumatic uterine rupture as among the leading causes of maternal death in the next decade. So we need to train health workers more on how to handle a gravity trauma patient, because many times we may have scanty knowledge on some of these things. Yeah, thank you.
Thank you so much, Dr. Henry Kaggwa, for taking us through this case of a 33-year-old woman who has two children and who is on her third pregnancy, who fell in on the floor in the toilet. I don't remember who fell and had a rupture of her uterus. Thank you so much for taking us through our journey, what we can do differently as a generation, and how to prevent it in the future. So, global citizens, I'm sure you enjoyed. I tried to put this in a story form, in as much as the publication itself is based on the life story of a pregnant woman. I tried to take us through the story form, put it in the story form, I mean, so we can understand better when we see a pregnant woman, how we should take care of her and how to prevent complications for her, such as traumatic uterine rupture. So thank you so much once again, Dr. Eric Kaggwa, for taking us through traumatic uterine rupture. I believe everyone has a good knowledge about traumatic uterine rupture, and we know how to help our friends, our neighbor, our families, and people around us to prevent and reduce the cases of uterine rupture in our environment. So this is a platform where research meets understanding. We're open to collaborations, partnerships, volunteering. So please reach out to us on firstecosystem@gmail.com. If you want to work with us, have a blessed week, everyone.